So today we're going to talk about mood disorders. Mood disorders are one of the most common psychiatric conditions. There's a lot of different types of mood disorders, and they're pretty much defined by their pattern of mood episodes. A mood episode is defined as a distinct period of time in which an abnormal mood is present. So some examples of this would be a manic episode, a depressive episode, a mixed episode, or a hypomanic episode. Mood disorders that are going to be discussed in this presentation will be major depressive disorder, which includes the subtypes such as seasonal affective disorder and postpartum, as well as a few others. Also dysthymic disorder, adjustment disorder, and the difference between adjustment disorder, grief, bereavement, and pathological grief, which would be more like major depressive disorder. Bipolar 1 and 2 will be talked about, and cyclothymia will be discussed as well. So the DSM-4 criteria for major depressive disorder. It states you need at least 5 of the following symptoms, and it needs to include either depressed mood or anhedonia. Now, anhedonia just means that they have the loss of pleasure in any sort of activity. So they don't get anything out of any sort of nice thing that they used to enjoy, like an older person who doesn't enjoy seeing their grandchildren anymore, or someone who used to enjoy reading constantly doesn't want to pick up a book and read. This would be anhedonia. The other thing is these symptoms, at least 5, need to be present for 2 or more weeks. So you can read the following symptoms below: change in appetite, worthlessness, guilt, insomnia, problems with their concentration, psychomotor agitation or retardation. So you will see in severe depression that these patients will move really slowly. They'll also talk really slowly. They'll have a loss of energy and sometimes suicidal ideation. Now remember, to make the diagnosis of major depressive disorder, they need to have at least one major depressive episode, plus they cannot have any history of a manic episode or a hypomanic episode. If they've had a manic or hypomanic episode, they'd probably have bipolar 1 or bipolar 2. So with major depressive disorder, you always specify what type that they have. So you say, for instance, major depressive disorder, comma, with psychotic features, or comma, with melancholic features, etc. So with psychotic features, during an episode of major depression, a person can experience psychotic features, so they can have voices, they can see things, hallucinations, have delusions, things like that. They can occur in a major depressive episode. In a major depressive with melancholic features, this is the typical classic type of depression that you see, where they have anhedonia, they have a lack of reactivity, so they don't respond to anything. If their friends come over, they don't light up at all, or if they're in the middle of something funny, watching a funny movie or something, they don't react at all. Their mood's typically worse in the morning, and then it gets a little better as the day goes on. They have early morning awakenings, psychomotor retardation, a loss of appetite, so they have weight loss, and feelings of guilt. With the major depressive with atypical features, these patients, it's a little different. They still have mood reactivity to some positive events, so they'll be able to go out and watch a movie with their friends and be able to react, but they're still feeling depressed. It's only a temporary reactivity. They also experience weight gain, hypersomnia, so they're sleeping way too much, and this thing called latent paralysis, which is usually described as a real heavy feeling that they get in their arms and legs. And they usually have a long-standing pattern of sensitivity to interpersonal rejection. Alright, postpartum onset. This is going to be discussed more in another slide, but basically it's when they get depressed within 4 weeks of delivery. Then you have major depression with a seasonal pattern, which is related to the seasons, and a major depressive disorder with catatonic features. And catatonia was discussed a little more in the psychotics chapter, but basically they maintain fixed positions, odd fixed positions for extended periods of time, and also displays things like waxy flexibility, and there's many other symptoms that go with catatonia. but you can see this in severe depression. So this is an easy way to remember how to assess for major depressive disorder with SIGI CAPS. It's a great mnemonic. All right, the epidemiology of major depressive disorder. Women are generally more affected than men. However, once they hit the age of 50 and on, the rates in women and men tend to equalize. So it makes people wonder if there's maybe a hormonal component to major depressive disorder. Average age of onset is about 29. There's no socioeconomic differences and no ethnic differences in the prevalence. You do see it more commonly in the elderly, and there's a higher incidence in divorce-separated patients or patients who lack a social support network. So the patients who have less friends are typically at higher risk to get this. There are some sleep changes that happen in major depressive disorder. You have initial insomnia, so they have trouble getting to sleep. There's what's called terminal insomnia. This is when they have those early morning awakenings. So they'll wake up at like 3, 4, 5 a.m. And this is with the more typical melancholic type of depression. Sleep changes for atypical depression are going to be more hypersomnia. So they're going to sleep a lot, and they're going to sleep during the day too. In all the different types of major depressive disorder, REM sleep shifts to earlier in the night. So as soon as they go to sleep, they go into REM a lot quicker than the average person. And they've shown they have less slow wave sleep, which is the stages 3 and 4. And their first REM period tends to be longer. So the etiology of major depressive disorder. There's a lot of different theories out there. The major ones that are accepted have to do with abnormalities in the neurotransmitters serotonin, norepinephrine, and dopamine. A lot of research is out there. They've done research on the neurotransmitters in the CSF of patients who've been depressed. They've also measured serotonin metabolites in people who have committed suicide, so this would be autopsy studies. And they found that there are decreased levels of the serotonin metabolite in the CSF of depressed patients. Dopamine has also been shown to probably play some sort of role in depression too, mainly because drugs that we prescribe that tend to decrease dopamine levels do have a side effect of depression, while drugs such as bupropion, which we use for depression, bupropion as well, Butrin, actually helps with depression. The other theory, or reason why this theory is accepted, is because our medications, SSRIs, tricyclics, and MAOIs, which tend to help increase serotonin, norepinephrine, these neurotransmitters, work to treat depressive symptoms. The bottom line is nobody knows exactly for sure what is going on, but these are some of the major accepted theories right now. So the genetics and prognosis of major depression, it runs in families. First-degree relatives are more likely to have it. The prognosis, most episodes last about 3 months, but if they're not treated, these episodes could last for 6 months, 7 months, even over a year. 13, 14 months they could go on for if they're not treated. That's why it's really important to get these patients into treatment. Also, the more frequent episodes they have, the worse their symptoms get, the worse their prognosis is. They tend to get worse each time they have an episode. And the risk of a subsequent episode is really high. It's about 50% within the first 2 years. Within the first 2 years after their first episode. So high relapse rate. Keep these patients on an SSRI or on their antidepressant for a while after they have their first episode to protect against this. And there's, of course, a higher suicide rate. Indications for hospitalization. You have suicidal, homicidal ideation, unable to take care for their basic needs, so if they're not eating, not drinking, getting dehydrated, that type of thing.